Okay, thanks very much for the opportunity for coming to speak today. So I've been asked to talk about how we might use medication, stratified medicine, to improve the safety of prescribing. We've obviously already heard a little bit about use of genetics and genomics in the area of prescribing. I'm going to start just by putting this in context. So most of the clinicians in the room, and indeed other healthcare professionals and patients, are very aware that one of the commonest outcomes at the end of a consultation with your doctor is walking out of the office with a slip of green paper with a drug prescribed on it. I was very interested that I tried to find out how many consultations end like this, and I found a paper from about over 30 years ago, which suggests about 58% of consultations end with a prescription. There's nothing actually more recent that I can find. But I don't think there's any reason to suspect this has changed. We've seen for the last 20 years a year-on-year increase in the number of medicines being dispensed in primary care, such that almost a tenth of the NHS budget is spent on primary care medications. That's over 1 billion items prescribed every year. This is work by Bruce Guthrie. I don't know if Bruce is with us today, but this isn't simply because there's more people about, but we've seen a 50% increase in the number of people getting 5 to 9 medications, a threefold increase in the number of people receiving 10 medicines between 1995 and 2010. So a huge increase. The sorts of medicines being handed out are the ones we might expect, ones that are commonly managed in primary care, both long-term conditions as well as acute health problems, so cardiovascular disease, central nervous system, so things like painkillers and antidepressants, management of gastrointestinal disorders and infections, and so on. And unsurprisingly, the older you are and the more things wrong with you, the more drugs you tend to be taking. So this graph shows more drugs towards the bottom in the red and black colours, and moving on the left-hand chart from left to right, we see increasing age, such that once you're in your 70s or above, a third of those people are on at least 7 or more regular medications. And we see similar patterns, unsurprisingly. The more health problems you have, the more drugs you end up taking. The other thing that seems to perpetuate this is the fact that we follow lots of evidence-based guidelines for single conditions, which generally advocate handing out lots of pills. NICE is handing out roughly 20 guidelines every year, and most of them look a bit like the diabetes guideline here, which at a number of different points is saying hand out medicines to patients. And of course, drugs can cause harm, and Munir is going to get picked on a lot today, I suspect, but this is, of course, work he published in the BMJ in 2004, showing that 6.5% of hospital admissions are accounted for by adverse drug reactions, and of those, the vast majority, around 80%, the drug is the direct cause of the admission to hospital. Of course, in primary care, we also, when we prescribe things, we often make mistakes, and this is Tony Avery's numbers from Tony Avery's practice study, GMC sponsored a study of primary care prescribing, which found that 1 in 8 patients in primary care are affected by medication error. Around 1 in 20 prescriptions are affected, and importantly, for every additional drug that a person is on, the risk of an error goes up by about 16%. And it's not just potentially about the actual errors themselves. We know that a substantial proportion of people are on medicines that don't actually seem to be effective in the first place, and that obviously shifts the balance of risks and benefits in an adverse direction. So can stratified medicine help deal with this issue of prescribing safety? Well, we've already heard quite a bit about genetics, but as Munir already hinted earlier, I think stratified medicine needs to be considered as more than that. So we can think about stratifying people according to age and gender, for example. We can use history and examination. So, does someone have a family history of X? That might influence our prescribing decisions. Obviously, blood tests that were already routinely available, so biochemistry tests, hematology tests, and imaging as well. All these things complement, of course, the more newfangled genetics tests that we potentially also have that are available to us nowadays. I think there's a number of areas where stratified medicine can achieve improvements in terms of prescribing safety. So the obvious one is reducing adverse effects, but there are other ones as well. So if we can improve efficacy of medicines, then again, we shift that risk-benefit ratio away from the risk, and it means we can avoid treating people if they don't need treatment or they won't benefit from it. I think by increasing the personal involvement of the patient, by saying this treatment is personalized to you, then you potentially get more buy-in from patients. That can improve adherence to medicines, and of course also potentially reduce adverse effects, which again improves adherence and persistence with treatment. And then finally, we can potentially get faster access to medicines as well. So considering, if we consider renal impairment, first of all, I would argue that stratified medicine is something we're already doing in practice all the time in terms of trying to avoid adverse effects of drugs. So there's over 2.5 million people in the UK who have chronic kidney disease of stage 3 or worse, and that's about 6% of the population. And a large number of drugs, as we all know, are cleared, excreted by the kidney. But despite the fact that in the British National Formulary, under every single drug, there's a little thing that says renal impairment, what to do for each drug, we don't necessarily very good at paying attention to what it suggests. So this is we'll blame the Americans first of all. So this is work on a US study of ambulatory care patients with renal impairment. And they found that 70% of those individuals were in receipt of at least one drug that was highly excreted by the kidney. So we're talking about common drugs here: allopurinol, digoxin, ACE inhibitors, atenolol. These are not unusual medicines. And importantly, of those people on those sorts of drugs, a third of them were receiving a drug above the recommended dose. We've seen similar things in this study in Canada of antibiotics, where ambulatory patients with CKD stage 4 to 5 who weren't on dialysis and in receipt of an antibiotic, and around 2/3 of those were receiving antibiotics at too high a dose. Before we get too hung up on blaming the North Americans, we're quite bad at it in the UK as well. So we've got a whole range of prescribing indicators, specific indicators of whether we are prescribing inappropriately in the UK. They're derived from things like the stop-start criteria, the Beers criteria. And quite a number of them focus on prescribing in patients with renal impairment. And this work by Jill Stocks and the BMJ a couple of years back showed that there's not an insignificant amount of prescribing of various drugs that are potentially harmful in patients with chronic kidney disease. And then, of course, the other section, the BNF, that says under renal impairment is hepatic impairment. What do you do there as well? So I thought I would choose antidepressants as a way of illustrating this, because we hand out a lot of these. Over £750,000 is spent every day in general practice on antidepressants, which I think is a pretty scary number, really. That's doubled in the last decade. And the commonest one is citalopram. We hand out 14 million prescriptions of citalopram every year, and that's the 16th drug in the league table of medicines. Now, citalopram has potentially important side effects. We've already heard from Imran that it can cause prolongation of the QT interval, which can lead in turn to serious ventricular arrhythmias. And there's evidence of a dose-response curve in the top left there between increasing dose of citalopram and increasing QT interval. Like many other drugs, citalopram is metabolized by the cytochrome P450 2C19 liver enzyme. So impaired metabolism can lead to a build-up of this drug and then potentially to increase adverse effects. And we do know that if the half-life of citalopram is about double in patients with, it doubles in people with cirrhosis compared with people who are otherwise healthy. And of course, we do regular liver function testing in primary care and indeed hospital practice for patients, and therefore picking up these sorts of things is relatively straightforward. However, we also know that the genotype of people indicating their metabolism of their 2C19 metabolism is also indicative of patients' citalopram levels. So the graph on the right-hand side there, we can see increasing levels of citalopram or escitalopram from the people who are ultra-fast metabolizers on the left to the poor metabolizers on the right. Now, we know about 5% of Caucasians are poor metabolizers, 20% of South Asians are poor metabolizers, and thus there is this potentially increased risk in those individuals. And there's limited data to suggest that impaired metabolism may indeed translate to an increase in QT interval. But that evidence is pretty weak at the moment. So I think we need something stronger before we can sort of support basing a choice of drug dose on genotype in this particular circumstance. But given dosing errors account, and this is again work from Tony Avery's practice study, given dosing errors account for around a fifth of all medicine errors in UK general practice, but I think it is potentially important that we think about how we can best make use of existing simple tests like renal function testing, liver function testing to optimize medication dosing. Could we use more sophisticated measures? Well, potentially yes. So Munir's smiling here because this graph's appeared once more. I'm of course going to say yes, it might help, but then I'm also going to put up this work by Stephen Kimmel, which came out in the same issue of the New England Journal, suggesting that actually the benefits of using genotyping to inform warfarin dosing was not perhaps as clear-cut as might be suggested by Munir's paper. Now, I'm not going to get into why that is because Munir will shoot me down in flames, no doubt. But I think what's clear is we mustn't think about other important things as well, such as using traditional good clinical algorithms, patient adherence, appropriate monitoring of patients as well. So those are other things as well. That said, having said, perhaps we need to be cautious about leaping in with genetic testing and so on. There are, of course, some very excellent examples of where genotyping is invaluable in terms of informing patient safety. So carbamazepine is one of the top 100 most prescribed drugs in primary care. Now, 80% of all Stevens-Johnson syndrome and toxic epidermal necrolysis, which are really nasty skin problems, are due to drugs, and carbamazepine is the most common cause. And although it's a rare condition, mortality can be as high as 30%. So this is a serious problem. And in 2007, the FDA in the States issued an alert advising screening for the HLA-B1502 allele in patients of East Asian and Southeast Asian ancestry. And such carriers, the odds of these skin reactions are around 80 times higher than non-carriers. So I've talked about safety, but what about improving the effectiveness of drugs? Because by improving efficacy, as I've said, we potentially improve that risk-benefit balance, and we increase patients' willingness to take medicines in the first place. So I think possibly one of the best-known examples of this, of course, is the NICE guideline on hypertension. So here we base the decision on initial treatment on whether or not a person is likely to have high or low renin hypertension. So a person aged under 55 with hypertension, we would start an ACE inhibitor, and someone over 55, we would start a calcium channel blocker. Another example from the world of cardiovascular disease, aspirin, fourth most common drug used in the UK. And a substantial proportion of people, about up to a quarter possibly, are aspirin resistant. So with point of care platelet reactivity tests and stuff available, perhaps there's a role for testing for aspirin resistance, particularly for those patients with recurrent strokes despite being on aspirin. Now, the evidence at the moment is pretty weak that using this sort of testing can be used to modify either the dose of aspirin or consider novel alternatives to aspirin as well. And we still use that sort of fire and forget approach when we're prescribing aspirin, but again, something to consider. The third area I was going to touch on was highlighting where stratified medicine has the potential to reduce delays in starting treatment in the first place, which again has potential important safety implications. So the obvious one here is antibiotics. We're a tool for hastening access to treatment. Has the potential to have major advantages, avoiding that need for best guess antimicrobial treatment, reducing the risk of exposure to unnecessary medicines, and ensuring that effective treatment is started in a timely way. Now, at the moment, there's no ideal way of doing this, and indeed the £10 million Longitude Prize, which is funded by Nest, has been set up with the ambition of addressing this very challenge. One approach that's already been considered is point of care testing as a way of improving the management of patients by identifying antibiotic sensitivities early. And the Poetic study, which is being run by Chris Butler in Cardiff, is looking at that in the context of uncomplicated urinary tract infections in primary care. So I'm sure we'll probably hear something about that later. So moving from asthma, which is infection, which is obviously an acute short-term problem that we're responding to. But let's also think about asthma as a sort of typical long-term condition, often managed in primary care. 1 in 12 adults in the UK are affected by asthma, and a substantial number, despite all we try, still have real problems with good management. 40% of patients hospitalised with asthma have raised eosinophil counts, and eosinophilic airway inflammation is associated with severe asthma. Eosinophils are in their differentiation, proliferation, survival is mediated by interleukin-5, and the introduction of anti-IL-5 monoclonal antibodies such as benralizumab has raised the prospect of improving asthma management for these people who are otherwise difficult to treat. So and trials have shown improved lung function, improved symptoms, and reduced exacerbations as well. I'm going to finish up by talking about implementation of some of this stuff. So there's clearly a whole host of tools available to improve the safety and effectiveness of prescribing in primary care. Some of these are already widely used, such as checking for renal failure, although we don't perhaps use them very well, don't act upon them. Some of them we actually do measure, but we don't currently use them in clinical practice. So I'm wondering how many clinicians in the room last looked at the eosinophil count on the full blood count, despite the fact you all do full blood counts on a regular basis. No one ever looks at the eosinophils. And other things such as genetics, of course, and point of care bacterial testing, which aren't readily accessible at the moment. So I think this is about both introducing new tests, but also being aware of the existing ones and making better use of those. So we've got all these tests, and of course they can be incorporated in various ways into different tools. So we widely use things like risk stratification tools. So QRIS, for example, is used for targeting cardiovascular risk management treatment in primary care. That's built into GP systems and so on, and widely used for targeting treatment. Prescribing decision support tools are very familiar to most GPs who obviously, unlike the hospital colleagues, have had the advantage of using computerized prescribing systems for many years now. And I think we might be hearing about some of those things later, but so there's tools like Optimize RX, which is built into many GP systems and flags up warnings and recommendations for changing medicines depending on patients' clinical history and the drug choice being made. But there are also some novel systems being developed as well. So we've got things like Genix, which uses genetic profiling to ascertain risk of adverse drug reactions. And then I think with the availability of a sort of plethora of consumer healthcare apps and direct consumer genetic testing as well, things like 23andMe, then the issue of treatment decision support arises as well. So this is support aimed at helping the decision-making process of patients rather than clinicians, and I think that's something that we're going to have to contend with. There's lots of reasons why, of course, these things aren't going to happen. So we've got excess warnings and decision support tools which can lead to alert fatigue. We've got a lack of infrastructure and access to particular tests and the necessary systems. We've got issues around things like privacy in the context of genetics, and of course things like time and cost always get brought up. We did some recent work looking at the introduction of novel ways of assessing cardiovascular disease, though, and actually the two key things that leapt out were the need for evidence to support the use of these things, and the need for these tools to be supported by policy and recommended in guidelines. Because if these two things don't happen, it's never going to. Clinicians will simply not use them. So my last slide, I thought I'd finish by highlighting the issue of education and training. So the term stratified medicine means little to most jobbing clinicians. And my wife's a GP, and I mentioned it to her, and she sort of glazed over. But she often glazes over, so maybe I shouldn't make too much of that. And if you mention something like genetics and SNPs in the same sentence to most GPs, they will think you're talking about male sterilization. So given that there's a continual shift of chronic disease management into primary care, I think there is a need to improve the awareness of these new developments and ensure that clinicians are adequately prepared to make best use of these new tools as they come in. But I think perhaps even more importantly, we need to also emphasize the importance of effectively using current approaches to stratified medicine, such as addressing the failure of clinicians to adequately use existing tools, such as renal function, to inform prescribing. Thank you very much.